And although we anticipate a resuscitation for every delivery that we attend to, there are certain factors which make a delivery a high risk delivery. Okay. So the antepartum conditions which causes that are advanced maternal age or age less than 16 years for a pregnant mother, poor socioeconomic status, detrimental habits such as smoking, drinking, drug abuse, maternal medical conditions such as diabetes mellitus, which is very important, and hypertension, CKD, lung diseases, kidney diseases, any chronic diseases, hematological disorders in the mother, and obstetric conditions such as prior stillbirth, prior birth of a high risk mm, baby, bad obstetric history, then antepartum hemorrhage, then premature rupture of membranes, sepsis during pregnancy, and of course placental anomalies such as placenta previa and the polyhydramnios, oligohydramnios, and all. Okay. Now coming to the fetal conditions which are associated with the high risk delivery, that is of course first and foremost is prematurity, post maturity also, intrauterine growth restriction, macrosomia, multiple gestation, and of course during birth complications of maternal medical disease can happen. Preterm labor, prolapse cord, uteroplacental bleeding, anomalies of presentation. Then there is sepsis such as chorioamnionitis, instrumental delivery, narcotics administered for mothers within hours prior to birth, CS delivery for fetal compromise. Okay, such things are associated with the high risk delivery where neonatal resuscitation is much more probable. Now, these are the neonatal resuscitation supplies and equipment that we need should a need for resuscitation come around. Okay, the warming and transport equipment and suction equipment and monitoring equipment. Okay, these three equipments we use even if there is no need for a most often we use even if there is no need for a proper resuscitation. There needs to be a preheated warmer with warm blankets, baby hat if necessary, or rather if available, a plastic bag or wrap for very preterm infants less than 32 weeks of gestation for preventing hypothermia, and a transport incubator also, especially for preterms only. Suction equipment such as either a bump suction or mechanical suction. Mechanical suction is usually preferred and it is now widely available in most centers. Okay. And a meconium aspirator, if present, it is good. And a monitoring equipment such as stethoscope, which is mandatory, and a cardiac monitor and pulse oximeter, if present, it is very good. Okay. Next is a source of free flowing oxygen, oxygen blender. This is not available in most of the centers because we are essentially a resource poor country, and if available, oxygen blender is very much high above the list, and face mask with appropriate sizing is mandatory, and a positive pressure delivery device such as a TP's resuscitator or a self-inflating ambu bag and an oropharyngeal airway. Intubation equipment has to be checked before every delivery. Laryngoscope blades of different sizes, handle and stillet. Endotracheal tube sizes 2.5, 3 and 3.5 usually, and laryngeal mask airway also. Vascular access equipment such as umbilical venous catheterization tray and supplies, and then peripheral intravenous catheters with securing supplies, needles and syringes, and medications such as IV epinephrine, novel saline, 10% dextrose, and sometimes naloxone also. So these are the different ET tube sizes which are required for neonatal resuscitation. Size 2.5 to 3.5 is commonly available and that is usually required only. And size 2.5 is usually for gestation ages less than 28 or weight less than 1000 grams or 1 kg. Size 3 and above, size 3, 28 to 34 weeks of gestation and weight 1 to 2 kg. And 3.5 size is used from 34 to 38, that is term. That is 2 to 3 kg. And if it is a macrosomia child or the child weighs more than 3 to 3.5 kg, usually a size of 3.5 to 4 will do. Okay, and laryngoscope size, number 0 laryngoscope blade is used for preterm infants and number 1 size is used for term infants. Okay, there is a 00 size also which is used for extremely preterm infants. Okay, and one more characteristic of laryngoscope blades that are used for neonatal intubation or resuscitation is that they are straight blades. Okay, the adult blades, and for older children we use curved blades, whereas for neonatal resuscitation it is always a straight blade. Now we'll go into the neonatal resuscitation protocol proper. Okay, it is known as the NRP. Okay, the NRP algorithm, it describes the steps that you will follow to evaluate and resuscitate the newborn. It is divided into 5 blocks, beginning with birth and the initial assessment. Throughout the algorithm, you will see that there is hexagonal boxes and rectangular boxes. Okay, the hexagonal boxes, they indicate uh, the assessments we have to do, and the rectangular boxes, they indicate the actions that may be required. Now we'll go into the neonatal resuscitation protocol proper. Okay. Antenatal team counseling, team debriefing, and equipment check has to be done. Then, as the order of resuscitation is TABC. Okay, remember that. Okay. Initial assessment, you have to check for cry and whether the baby is born as term baby and how the tone is. Okay. If all these are normal, baby can be shifted to the mother side. Okay. After routine steps of warmth, drying, stimulating, and positioning airway, clearing of secretions if at all any are present. Okay. Then we shift to other side. Okay. Even if there is no cry initially, the routine the routine care steps has to be done first. Okay, that is the most important thing. Okay, even if a baby is coming to you without crying first, still you have to follow the first step, that is warm, maintaining normal temperature and airway positioning and clearing of secretions. Okay, and still if there is no cry, assess the heart rate and respiratory effort. Okay, in significant hypoxia, decrease in heart rate is the first physiological change that will happen. Okay. And suppose if the heart rate is more than 100 with labored respiration and cyanosis, oxygen supplementation via an oxygen hood or a CPAP delivery machine will be necessary. Okay. And if the heart rate is less than 100 with the child not breathing or the baby not breathing, you have to initiate positive pressure ventilation via bag and mask or via ET tube and intubation. Okay. Then, if at all you have to do resuscitation and you have to give CPAP or you have to give bag and mask ventilation, the head position should be proper. Okay, this is a correct position. I hope you can see my pointer, the reddish marking. Okay, this is the correct exact position. Okay, it is known as a sniffing dog position. Okay, not too much flexion, not too much extension. Okay, the second picture shows us the excessively flexed posture, which is incorrect, and the third picture shows us the excessively extended, that is hyper extended position, that is also not correct. Okay, the correct position, if we put the child in, there will be an alignment of the posterior pharynx, larynx, and trachea. Okay, which helps in an unrestricted air entry. Okay. And so, when you have to give positive pressure ventilation, first line is definitely bag and mask ventilation. Okay, it is known as non-invasive positive pressure ventilation. Okay, the usual bags that we use, they range from a volume of 240 to 750 ml. Okay, that much volume of air is there in the bag. Okay, and there is a reservoir bag which increases the concentration of oxygen that is delivered. Okay, when it is connected to a port. Okay, and how we should do the technique is extremely important. Okay, wrongly performed resuscitation is much more dangerous than a baby not receiving resuscitation at all. Okay, most often. Okay, and how should we do the mask should be appropriately sized. Different size masks are there which we should check prior to the delivery. Okay, prior to every delivery we should check. Okay, the mask should cover both the nose and the mouth. Okay, and the response after bag and mask ventilation should be increased heart rate, improvement in baby's color. Okay, if there is no response, you have to check the ventilation corrective steps. Okay, that is known by the acronym MR-SOPA. Okay, what is MR-SOPA? As per the protocol, you have initiated the bag and mask ventilation. Still, you are not seeing any positive response. Then, instead of going to the next step, you are supposed to check for any corrective steps you have to do in the bag and mask ventilation, such as mask readjustment, repositioning of the head, suctioning of the child's airway, opening of child's mouth, increasing your positive pressure ventilation pressure, and planning for any other alternative airway. Okay, so the short form, the acronym for this is MR SOPA. Okay, so once again, let's go through the position and the ideal way you have to do the hand. Okay, the rescuer's hand is positioned so that little the little finger, the ring finger, and the middle finger. Okay, they are spread over the mandible from the angle of jaw forward towards the chin in the configuration of the letter E. Okay, E. Here it is written E. Okay, and the jaw is then lifted, pulling the face into the mask. Okay, jaw is lifted, pulling the face into the mask. Okay, the thumb and the forefinger, they are placed over the mask in the shape of the letter C. Okay, I hope you can see this. Okay, and the mask is squeezed onto the face and a seal is formed between the mask and the face. Okay, I hope you got that. Okay, that E and C position. Okay, and at what rate we have to give? 40 to 60 breaths per minute. Okay, which is the normal range of respiration for a newborn. Okay, okay, and the higher pressure has to be given for the first breath, and subsequent breaths lower pressures can be given. Okay, the fraction of inside oxygen or FiO2 is 30% for preterm, which can be titrated according to the saturation values. And for a term baby's resuscitation, first we always prefer room air resuscitation, that is plain room air, 21% oxygen. Okay, and only one condition is there as the absolute contraindication for bag and mask ventilation, that is CDH. CDH means congenital diaphragmatic hernia. Okay, here if we do bagging, the CO2 can enter the intestine and can dilate. Okay, which can further compress the lungs and can worsen the already existing respiratory distress. Okay, so suppose even after the back and mask ventilation, the heart rate is still less than 100 per minute. Then what do we do? Then we check for the chest movements, we correct ventilator corrective measures, and we do then, which we already mentioned. And still, if the heart rate is less than 60 per minute, we have to go for chest compressions first. Okay, okay. So chest compressions you have to do in the ratio of 3:1. Okay, for the okay 3:1. That is 90 chest compressions plus 30 ventilations in a single minute. Okay, okay. And afterwards, if you are already doing chest compression, it is always better to into. So the ET tube sizes and appropriate gestational age and weight categorization we already mentioned. But a few points that you should know is that straight blade laryngoscope is used, and we always prefer ET tubes that are not cuffed. Okay, uncuffed ET tubes are preferred for newborns, and the inner diameter of the tube is always the size mentioned. Okay, this 2.5 size and 3.5 size we indicate the inner diameter of the tube. Okay, and the length of insertion, it is roughly 6 plus the weight of the baby. Okay, suppose it is a 3 kg baby, the length of insertion is up to the marking 9. Okay, and the best way to confirm ETT position is ETCO2 capnography. Okay. Okay, so the first method of chest compression. Okay, there are two methods. The first method is the two-finger technique, which is typically used when there is only a single rescuer for resuscitation. Okay, you need to follow this line. Okay, I hope you can see the pointer. This is the nipples. Okay, these are the nipples of the baby, and this is the intermammary line. Okay, or you can also call it as a nipple line. Okay, just below the nipple line and just above the syphis sternum. Okay, this area where I'm pointing right now is where you should put all the pressure into. Okay, chest compressions may be performed with two fingers placed on the sternum as shown in this figure just below the nipples. Okay, this picture shows the site of compressions, and when compressions are performed, the two fingers used should be perpendicular to the chest and they should be straight. And now this is the two thumb technique when there are multiple rescuers available. Okay, there also the nipple line is the same. The position of pressure, the position where you have to give pressure via compression is also the same. Okay, the thorax is encircled with the hands. Okay, and cardiac compressions are performed by both the thumbs. Okay, the compression side is approximately 1 finger's breadth below the nipple line. Okay, the area of the xiphoid process should be avoided so as to not to cause injury to the liver, spleen, or the stomach. And so, if the heart rate is still less than 60 per minute, even after giving chest compression, adrenaline has to be given. Okay, it has to be given either intravenously via the umbilical venous catheter or intraosseously or even intratracheally. Okay, if you are giving via the IV or IO route, the dose is 0.2 ml per kg of 1 is to 10,000 solution. Okay, that is a recent NRP change which we will go through later. And if there is no response even after giving adrenaline, volume expansion with IV fluids has to be tried. Okay. And still if there is persistently bradycardia is there, consider pneumothorax also. Okay. And then these are the medications which we use in neonatal resuscitation: epinephrine, isotonic saline, and very rarely sodium bicarbonate also. Okay, what does adrenaline do or epinephrine do? It increases the cardiac output by increasing the heart rate and myocardial contractility, also increases BP by causing peripheral vasoconstriction. Indication is bradycardia less than 60 per minute despite adequate ventilation and chest compression. Okay, that is the catch there. Okay, and the dose is actually zero point 0.1 to zero point 0.3 ml per kg intravenously of 1 is to 10,000 solution. But now with the recent NRP, the 2020 neonatal resuscitation protocol, there is a change. For convenience, that is taken as a fixed value of 0.2 ml per kg of 1 is to 10,000 solution. Okay. And a few facts which is mandatory. The first 1 minute of neonatal resuscitation is known as the golden minute. Okay. And the first 30 seconds, it is PPV to initiation of chest compressions, and the next 30 seconds is chest compression to initiation of adrenaline. Okay. So the whole process up until adrenaline you have to finish within 2 minutes. 2 minutes. Okay. That much quick and that much objective you have to be. And withhold resuscitation after 20 minutes of all steps. Okay, that again is a new change. Okay, that again is a new change. Earlier it was 10 minutes. And these are the new changes. Now the new edition is NRP 2020, that is the 8th edition. Okay, the changes you need to know from your level are that the dosage changes of adrenaline. Okay, earlier it was a range dose, that is 0.01 to 0.03 mg per kg, or rather 0.1 to 0.3 ml per kg. Now for convenience purpose it has been changed to 0.02 mg per kg or 0.2 ml per kg. Okay, and also the time frame cut off for stopping resuscitation has been hiked to 20 minutes. Okay, officially. Okay, in practice the cutoff was put as 20 minutes even long back, but now it has come to as an official change.